Good evening, everyone, and thank you for joining us for tonight's Woo You event. We have Dr. Caitlin Sapoznik here, and her title of her presentation is OCT and OCTA Imaging in Diabetes and Diabetic Retinopathy. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Zeiss Imaging for exhibiting at this event. Please stay tuned for the sponsor presentation following our CE because they will have a special promotion for attendees that attend the sponsor presentation. This will be worth 1 hour of CE, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, if you could fill out the survey link that's in the chat, and it'll also be there when the webinar ends. CE certificates will be delivered via email and sent to Arbo with your OE tracker numbers, and you should receive those within about 4 weeks. We will also have a QR code that you can use your OE tracker app on your phone to get that credit instantly. And then we will save questions for the end of the presentation, so you can ask those either in the chat section or the Q&A at the bottom. And then if you're on your phone, you can find the Q&A button at the top or the chat button under the 3 dots under More. So I'm super excited to introduce our speaker tonight, Dr. Caitlin Sapoznik. So she is a clinician scientist with expertise in retinal imaging. We were talking a little bit before she joined University of Houston College of Optometry in 2021, does clinic part-time, and then spends the other part of our time in clinic on the frontline research of all things OCT and adaptive optics imaging. So we are hearing from somebody that gets to do research and practices it in clinic as well. So her background is that she graduated from ICO in 2013 and then completed a ocular disease residency at Indiana University School of Optometry. After her residency, she did a PhD in vision science at Indiana University. Now she's, as mentioned, an assistant professor at U of H, and she at her lab she uses resolution retinal imaging techniques such as the adaptive optics scanning laser ophthalmoscopy. it's gonna I'm too tired to read big words right now. And OCT to study retinal vascular biomarkers in ocular and systemic disease. So we're super excited to hear from her tonight. We have no financial disclosures, and I will have you take it away from here, Dr. Spoznik. Thank you.
Thanks, Dr. Sorenzi, for the introduction, and good evening, everyone. And thanks to Wu University for inviting me to speak to you tonight about OCT and OCTA imaging in diabetes and diabetic retinopathy, which is one of my favorite things to talk about. So, of course, we can't do any presentation on diabetes without emphasizing just how big of a problem this is in our healthcare system. And this is an issue globally and in the United States, but we're now up to about 15% of the US adult population that has diabetes, and another 38% of US adults have prediabetes. So this is over 50% of our population that has some sort of metabolic dysfunction. And of course, with diabetes, we have both vascular and neuronal complications, so the retina is really important here. Diabetic retinopathy is a leading cause of new cases of blindness in working age adults. So about 12% of adults with diabetes end up having severe vision difficulty or blindness. And of course, clinically, we really grade this as sort of the spectrum of vascular changes that occur in the retina, but it also affects the neuronal retinal tissue as well. Now, the cases of diabetic retinopathy in the United States from the year 2000 to 2010 almost doubled, and by 2030, which we are nearing in 2050, those rates are still going to continue to increase among all demographics. So it's really important that optometrists are continuing to be the primary eye care providers for patients with diabetes. We have an opportunity to make such a huge difference here. And I think it's really important for us to also make sure we have the best technology in order to monitor and manage and detect patients that have diabetic eye disease disease. And so traditionally, we've been using retinal imaging modalities for an extremely long time for diabetes, right? We were using fundus photography, particularly stereoscopic fundus imaging, as well as fluorescein angiography. But we've come a long way since then. We now have wide field imaging, such as the Optos or the Zeiss Claris, where we can now know that some of these patients with diabetes even have predominantly peripheral retinopathy. But really, probably what I use most in my patients with diabetes, and I imagine what a lot of you use most too, is OCT and OCTA. And I really use the structural OCT primarily to detect and monitor diabetic macular edema. And also, I'm now using OCTA more and more because we're learning more and more about what OCTA can tell us that we can't glean from our fundus examination or from a regular OCT. And so tonight we're really going to focus on these technologies, how to use them in diabetes. We're briefly going to review just how OCT and OCTA work, review clinical grading of diabetic retinopathy, and then we're really going to shift and focus on diabetic macular edema because OCT has really made such a difference here, and we even have a new OCT-based classification system for diabetic macular edema. And then we're going to move in to talk about OCTA. So just in case you need a quick review, and I'm going to try to move quickly through these. When we're using our OCT, which is essentially a fancy interferometer, we have a light source, and it's being sent to both a reference mirror as well as a sample. In our case, this is the retina. Light is reflected back both of these, and the interference pattern is then sent to the detector. So the different retinal layers are going to reflect light differently, and so we start to see hypo and hyper reflective bands of the different types of tissue in the retina. And so we really end up getting sort of this optical biopsy of the retina because we also have excellent axial resolution with OCT. And here's just a review of the nomenclature for the different layers in OCT. And then moving into how OCTA works, we're really utilizing the motion contrast of blood moving through the retinal vessels. So we're still using the same type of system that we're using for our regular structural OCT, but as technology has advanced, the scan rate has become much faster and is allowing us to utilize this software integration into a lot of systems that you may already have, and then systems that are continuing to improve. But essentially, all the retinal tissue is going to be stationary except blood flowing through the retinal vessels. And so with a very fast OCT, you can take a series of repeated B scans at the same location. And when you have variance in the amount of, or in the intensity of the voxels, or you can think of those as 3D pixels because we're imaging in 3 dimensions with OCT. But when you have variance, that is when blood flow or movement is detected. And so you can get these maps where right here, all of the red that's being shown in this B scan is areas where there was motion detected from these repeated B scans in each of these 3 locations. And then when we put that all together, we can end up getting this en-face perfusion map that's reconstructed. So clinical grading of diabetic retinopathy that we're still using today is really based off of fundus photography and the early treatment for diabetic retinopathy study. Of course, we can also have macular edema at any stage, but it's really the spectrum of vascular changes that we're using. And OCTA and OCT are really valuable at all of these stages. This is just a quick review of the diabetic retinopathy disease severity grading scale. And this is what I primarily use in clinic, but I always like to remind myself why we follow these different stages of diabetic retinopathy in the time intervals we do. And it's because of these progression rates. So even when we get to just moderate PDR, we are having a quarter of those patients progress to PDR within a year. But we also have diabetic macular edema, right, which has its own separate classification system. And this can occur at any level of retinopathy. It's the most common visually impacting diabetic retinopathy complication. And this is when we have retinal thickening from fluid accumulation. We've had a breakdown of the inner blood retinal barrier, the upregulation of VEGF and other vascular factors in our patients with diabetes causes that retinal vasculature to become hyperpermeable, and we can get lipid, we get exudates, we get protein that's leaking into the retina. And this has really been historically one of the primary reasons why we've been using OCT so heavily in our patients with diabetes, because it allows us to better detect macular edema and allows us to really monitor it very well. And so how we're classifying DME is changing. So, of course, clinically significant macular edema is probably what most of us learned and most of us used for quite a while. And really, if you fit any of these three criteria, you have clinically significant macular edema, and we would refer you to a retina specialist to get probably focal laser photocoagulation or grid laser. But this was defined in 1985, so prior to the advent of OCT and OCTA, and this grading scale became a little bit dated because our treatment for DME, our first-line treatment, has completely changed over the last 20 years. We're now using anti-VEGF as the primary intervention versus focal laser coagulation or corticosteroids. I rarely see patients get those treatments anymore. And when a lot of the anti-VEGF clinical trials for diabetic macular edema were done, OCT and the thickness on OCT was really one of those primary endpoints. And so retina specialists right away started adopting using OCT to manage these patients. We started using it in order to monitor our patients and refer our patients when they needed to be referred. And it allowed us to pick up macular edema much more, it was much more sensitive than our clinical examination or even fundus photography, since we're getting that cross-sectional high resolution image. And so it's changed how we treat DME a lot, and we even have a new staging system for DME based on OCT within the last 7 or 8 years. So we're going to talk about the staging based on OCT, as well as some biomarkers that might help you better understand or give you some insight into your patient's vision, just in case you have some of those cases where patients don't improve after treatment as you might expect. And when we look at the diabetic retinopathy preferred practice patterns from the American Academy of Ophthalmology, one of the reasons we're usually doing OCT again is to detect, quantify, and monitor DME, and to evaluate patients with difficult or questionable examinations for DME. And so this is really how I use it all the time, as I'm sure all of you do as well. And for a long time, we've been able to look at the different types of DME morphology on OCT. We didn't necessarily need the high resolution that we have today to look at these different morphology types. But now that we do have a little bit better resolution and better software integrated into our OCT systems, we can really get reliable quantification of the retinal thicknesses. And this is on every OCT machine. There's normative databases for retinal thickness that have been established, and we're also able to do longitudinal monitoring very precisely with OCT. It also allows us to very accurately localize edema. And again, as I mentioned, it's already been incorporated into many clinical trials looking at the efficacy of anti-VEGF for DME in addition to visual acuity. And so again, since we've been using it clinically for so long, it just makes sense that we have a more modern classification system based on this technology for DME. But we can easily monitor our patients. This is a patient that I saw with very severe diabetic macular edema, right? We're up at the, we're at 641 microns here. We see them 6 months later, and we can get the exact same cross section and have this really nice chart to see how their diabetic macular edema is changing. In this particular situation, they never were treated, but they had better systemic control, so they were improving somewhat. And when we're quantifying thickening on OCT, one of the key things that's extremely important to use is your early treatment for diabetic retinopathy study, or your ETDRS grid. This image is from a spectralis, but Every OCT system will have a way that you can overlay this ETDRS grid, which becomes very important because we use these different subfields to assess how close or far away we are to the fovea. And of course, what we really care about most is this central subfield thickness, or the center 1 millimeter subfield, because that encompasses the fovea and the perifovea. And so this area, if we have any abnormalities, in the case of our diabetic patients, edema, if the vision isn't already affected, the vision is certainly threatened if we have edema in this location. And when you look at a lot of the clinical trials, when we were implementing anti-VEGF or comparing the different anti-VEGF drugs that we can use for DME, particularly by the drcr.net, they were using this central subfield thickness as an outcome measure to determine how efficacious those drugs were. And then here is that same patient I just showed you, but now we're looking at it from sort of an en-face view with this thickness map, and we can see that the central subfield is extremely thickened, and obviously this patient's fovea is involved, which this is a very obvious case, right? But for some of these more subtle cases, this comes in handy. And so now we have this updated, more modern OCT-based diabetic macular edema staging. So we have diabetic macular edema that's either center involved, which means that that 1 millimeter central subfield is affected, or we have non-center involved diabetic macular edema. But we've even taken it a step further. So the drcr.net has also evaluated whether all center involved DME actually needs treatment. And in particular, they looked at center involving DME with good visual acuity to determine if it benefited from treatment versus just close observation. Okay, so these are people that have some degree of center involved DME, so that center subfield is certainly affected, but they still have good visual acuity, so better than 20/30, so 20/20 or 20/25 visual acuity. So this was a very large clinical study with multiple sites. And what this study found actually is that in patients with good visual acuity, when we look at our baseline compared to 2 years, and these are box plots showing the aflibercept group or anti-VEGF group, the laser group, and the observation group, there's no statistically significant difference here, regardless of if they were treated or just observed. And same goes for the central subfield thickness. So we look at our 2-year time point. Again, there's no significant difference between these three groups, okay? So what this means is that with good visual acuity, observation may be reasonable for these patients. So we are further going down this tree of how we classify diabetic macular edema, and we have now center-involved DME with preserved visual acuity, or center-involved DME with associated visual acuity loss. And this is just sort of a little flow chart of what you would do with these patients. So if you have non-center involved DME, you are going to either closely monitor them, or occasionally those patients may still get focal or grid laser. Again, I rarely see that happening, but it does sometimes happen. Or if they have center-involved DME, if they have good visual acuity, then again, close observation, or they may have focal or grid laser. But if they don't have good visual acuity, those patients need to be referred for anti-VEGF therapy. And again, we're just looking at this table from the preferred practice patterns, looking at sort of how to follow up with the patients that have center involved versus non-center involved DME based on their stage of diabetic retinopathy. And I want to point out here that this little cross, the little note that is associated with this just talks about how the treatment may be guided. There may or may not be treated based on what the patient's visual acuity is. But the follow-up for these patients, regardless of if visual acuity is affected or not, should still be, they should be very closely monitored. Now, when we go to non-center involved DME, these patients are usually okay to just monitor, right? With mild and moderate NPDR, these patients are usually not treated with anti-VEGF therapy. Again, sometimes there may be focal or grid laser performed. When we start to get to severe NPDR, now it becomes sometimes non-center involved DME may be treated, and that's because once you're at the level of severe NPDR, there is some evidence that anti-VEGF can sort of prevent the progression to PDR, which is still sort of up in the air how efficacious that is, but these patients are more likely to be treated at this later stage of NPDR. And of course, I'm not even highlighting any of this with NPDR patients because those are an automatic referral to a retina specialist for me. So there's been a little bit back and forth of whether macular laser should still be preferred, and the jury's still out. There's still some debate on this. But again, personally for me in my practice, I don't see a lot of patients getting focal grid laser. When I do, it might be because there is one sole microaneurysm that is the cause of the leakage. And so the retina specialist feels that that is a more permanent solution versus repeated anti-VEGF injections, but usually those patients are getting a fluorescein to really assess that as well. I'd be interested to hear what all of your experiences are with that as well. So moving into a few cases of DME, really trying to highlight, though, that what I just told you about this classification system is not quite so black and white. So this is a 51-year-old white male, a type 2 diabetic for 15 years, treated with metformin, a short-acting GLP-1 agonist, and has peripheral neuropathy. His A1C was unknown, but recently he had just been restarted on his diabetic medications. He had lost insurance and couldn't afford his meds, and so his blood sugar had gone from sky high to very low in an extremely quick period of time. So this patient's visual acuity is 20/20 in both eyes. So of course we're doing an OCT on this patient, and it doesn't look too great, right? We can already see that this cross section right through the fovea, we've got a lot of sort of diffuse edema. We don't necessarily have these big cystoid spaces, but that central subfield is certainly involved. And then when we look over at this thickness map, we see that it's involved, but we also see that this patient has very, very diffuse edema of their entire sort of posterior pole. And so this is a patient that technically has good visual acuity. Do we monitor or refer this patient? So some things you always need to consider when making that decision is whether there's diffuse DME, the level of retinopathy in this patient in particular. They had severe NPDR, and their recent history. So again, they had that very quick decrease in blood sugar and weren't very well controlled. So this is somebody that we ended up, of course, referring for treatment, where it's center-involved DME at the stage of severe NPDR is usually treated. And so unfortunately, that patient did not get treatment. Again, they were having some insurance issues, and they had some other more life-threatening complications from their diabetes where their vision wasn't the priority. But they did come back 4 months later, and we can see now that this edema has worsened. We even have this subfoveal detachment. So we've now got a breakdown of the RPE barrier as well, and now the visual acuity is reduced. And unfortunately, this patient was never treated, but certainly somebody that the first time I saw them, they would be getting a referral regardless of what their acuity is based on that amount of edema. This is a more subtle case. This is a 63-year-old white female, very well controlled, no visual complaints, just here for her annual exam. So we do an OCT, and we see these very focal little cystic spaces in her retina. When we look at the thickness map, and in particular that central subfield, it's really not affected, right? This area of edema that corresponds to those cysts that were just seen in that B scan is well outside of that center subfield. And so this is somebody that I felt very comfortable monitoring. We monitored her for quite some time without any change. And this is really in line with what these preferred practice patterns tell us, that it is okay to monitor these patients. I do want to point out on this patient, though, that you can see this microaneurysm right here that is associated or nearby, I should say, with that leakage. So whether or not it's causing it directly, I can't say, but it's certainly a possibility. And OCT, you can actually visualize, especially more medium to larger size microaneurysms quite well. Sometimes they have a more dense kind of capsule around them, which may be protective in a sense from leakage because they might have some thickened wall structure there and some hyalinization, whereas these more discontinuous capsules around microaneurysms are more likely to be associated with some cystoid spaces. This is a 70-year-old Black female. She came in for a diabetic eye exam. She had failed a screening at her PCP's office. She didn't really plan to get an eye exam until they told her she needed to. She was another type 2 diabetic for 15 years and also had some other comorbidities. A1C is not great, so she was not very well controlled, but visual acuity is still quite good. When we look at our OCT, however, and this is an example from the Cirrus OCT, just to point out how different OCTs look, and this is in the Forum Retina workspace. This is the ETDRS grid. That center subfield is certainly affected and definitely thickened. And she also has this very large cystic space and exudate that you can see, as well as this vitreomacular traction, which may contribute to worsening of DME. So technically, this patient does have center-involving DME with good visual acuity, but they also have VMT. They have mild to moderate NPDR. And when we started talking to her a little bit more, she was complaining of changes in her left eye, which is where she has the macular edema. So we know that 20/20 vision does not always equate to good vision. So this was somebody that certainly had noticed a change in her vision. So we went ahead and referred her to retina. She was treated for quite some time. About a year later, she's now on sort of this extended treatment of aflibercept, but she's doing quite well. Her retina is nice and flat and visual acuity has been preserved. So just refer, monitor non-center involved DME. Of course, if they're at the level of severe NPDR or PDR, I would be referring those patients. I think I feel pretty comfortable to monitor these patients because I have access to a lot of tools at the clinic here at UH. So I have an OCT, we have a retinal specialist here, and I'm pretty comfortable with this. If you don't have quick access to a retina specialist, maybe it might be somebody you want to go ahead and refer. Patient compliance is a big thing here too. Do I think they're actually going to come back every 3 to 6 months as I want them to? Do they live close enough where they can easily come back in that time interval? Or do I need to set them up with an ophthalmology or optometry closer to where they live, since they're going to be now on a more regular follow-up timeline? And then is the edema diffuse versus focal? A lot of the focal edema I definitely feel more comfortable with than diffuse edema. I tend to see more diffuse edema in very uncontrolled diabetic patients or patients whose diabetic retinopathy is progressing. So that makes me a little worried that the patient's going to continue to progress, especially if it's close to that center subfield. And then, of course, socioeconomic considerations need to be made as well. Center-involved DME, of course, if there's decreased acuity or if they have severe NPDR or PDR, I certainly am referring these patients. Good visual acuity, again, is a little bit more up in the air and really need to assess the patient as an individual, look at more than just the OCT, take a lot of the same considerations for non-center involved DME that we just talked about, as well as if they have visual complaints, as in the last case that I showed you. Have they had DME treatment in the other eye? Is their edema worsening? Maybe you're bringing them back for that 3-month follow-up and their vision's still good, but the center subfield thickness has increased. So these are all things that you just have to consider and decide what you think is best for the patient. And again, you're going to be following up these patients very, very closely. So sometimes the ones that I have a hunch that I think they're going to progress and lose vision, I'm going ahead and referring them to retina so they don't waste their time with me at the next visit, and they get in for that retina consult and can get treated a little sooner. Now, one thing I also think you need to be very aware of as you're considering these guidelines and this staging system is that about 1/3 of the patients in Protocol V that were originally assigned to just the observation group, 1/3 of them ended up having a decrease in visual acuity over the study period. And so they were immediately then moved to the aflibercept group. And so, or treated with aflibercept, I should say, or treated with anti-VEGF. So that's a pretty big chunk of those patients that were observed. And it tended to be people that had thicker retinas from the beginning, more severe stages of diabetic retinopathy, and ones where the non-study eye or their fellow eye had macular edema treatment. So these are important things that you need to consider when you're deciding whether to monitor or refer these patients. Now, sometimes I have patients come back, they've had anti-VEGF therapy, they're doing what looks very well on the OCT, but their visual acuity isn't quite what I would expect. And these are two more subtle biomarkers or more subtle findings that you can look for on your OCT, maybe in those patients where the visual acuity just isn't as good as you would have thought it would be after treatment. And the first one is drill, or disorganization of the inner retinal layers. And basically what we're looking at, we're focusing on that center 1 millimeter, right, that encompasses the fovea. But what we're looking at is when we look at these inner retinal layers, you really can't delineate them very well on this side. There's no easy way to segment those different layers. You're not seeing those very nice laminar bands that we're so used to seeing. And so these patients generally have worse visual acuity and a worse visual acuity prognosis, even with treatment for DME. On this side, we're seeing a patient that has very obvious retinal thickening and edema right in the fovea, but their inner retinal layers are still preserved and still very laminar, like we like to see. So probably what's going on is maybe there was chronic edema or very severe edema that really kind of permanently distorted the organization of those layers. And so those neurons and all that tissue there just can't properly fire that signal back out to the ganglion cells and through the optic nerve. And drill is very well correlated with decreases in visual acuity, as well as decreases in contrast sensitivity and perimetry. Now, this isn't something that I am looking at very closely on every single patient, because when I'm diagnosing a patient with DME, there's no tool that I can easily measure this. But I think clinically, again, when you have those cases come back that just don't make sense why their vision hasn't improved despite their retina looking dry and their thickening decreasing after treatment, this is something to kind of look at to see if this is present or absent, and may clue you in to sort of just why that patient has the vision that they do. Another one is ellipsoid zone disruption. And the ellipsoid zone band is right here. It goes by many names. So the inner segment, outer segment junction, the ellipsoid zone. There's a lot of debate on what this band actually represents. But historically, it used to be called the pill line or the photoreceptor integrity line. And I still think that's a great name for it, because it really does tell us the status and the integrity of the photoreceptors, and is very highly correlated with vision and visual function. So if we're looking at this ellipsoid zone in patients that have active diabetic macular edema, there's different things that can happen. Here we see that this band is definitely a little hyporeflective in certain areas. Right here in this next image on the right, it's actually missing. Here we have sort of this segmented less hyper reflectance than what we should see. And here we can see some disruption as well with that ellipsoid zone. And so again, you're really not going to know the status of their retina until they go through treatment, but there's sort of a thought that if there's chronic edema or very severe edema, and maybe it sits there, they don't get treated right away, they don't come in, maybe there's going to be more likelihood for more permanent damage to the retinal layers, which could be that you see ellipsoid zone disruption after they've been treated and they still have poor visual acuity, or maybe they have drill. So just a little more insight into your patients with using structural OCT. And now we'll move on to OCTA for diabetes and diabetic retinopathy. And of course, I say diabetes because we know that OCTA now is showing us all sorts of preclinical and subclinical changes before we can even detect diabetic retinopathy. Now, usually when we're looking at a OCTA slab, we're looking at the superficial vascular complex and deep vascular complex. Depending on what machine you have, these might be labeled a little bit different, and they actually might be segmented a little bit different. So there's been some proposed nomenclature for OCTA capillary plexuses and complexuses, but there's no really agreed upon nomenclature, no agreed upon way to segment these different slabs. And this sort of shows you, this is from Heidelberg, but it shows you how the spectralis is going to segment their different vascular complexes versus the Avanti, versus the Cirrus, and then versus that publication that I just showed you that's very well known. So every machine does it a little bit differently, which is an issue, right? Because that means we can't compare these patients directly between machines, and makes getting good clinical studies done well when the different instruments are doing different segmentation and there's no universally agreed upon segmentation for these different vascular layers. But what we do know in general is that OCTA tells us a lot, right? We're really getting perfusion status very non-invasively in these patients with diabetic retinopathy and diabetes, and we're seeing a lot of these subclinical vascular changes. We can detect microaneurysms you might not pick up on your clinical examination. We can look at alterations to the foveolae vascular zones, so you'll often see enlarged foveolae vascular zones in patients with diabetes because they've had a capillary dropout and non-perfusion within that area. We can get perfusion mapping. We can calculate things like vessel density. And of course, vessel density decreases as severity of DR increases. And we can also see macular ischemia and neovascularization. You know, before, when I suspected a patient had macular ischemia and I was running just a structural OCT, it might be that those patients, the layers in general, the entire retina just looks thinned. Now with OCTA, we can really confirm how much perfusion they have lost. And then, of course, we can look at neovascularization as well. And so these are two examples of patients with diabetes. This is a more severe diabetic retinopathy patient. We see a lot of irregularities, a lot of dropout of the capillaries, enlargement of the foveolae vascular zone. And then we have somebody with less obvious retinal changes. So these white asterisks are just pointing out these very small areas of perfusion deficits, or areas where there's been some capillary dropout. And in both the deep and superficial vascular complexes, there is a decrease in patients with diabetes. And this is actually in patients with diabetes that don't have any clinically detectable retinopathy. So again, we're seeing capillary non-perfusion even before we can see changes on our clinical examination. In the left, this is showing a perfusion map in the foveolae vascular zone of a normal patient. When we look on the right, this is a patient with no diabetic retinopathy, and we can see that that foveolae vascular zone is irregular, enlarged, as well as some decrease in the perfusion there. These vessel density measurements are going to decrease, right? We're getting more non-perfusion and more capillary dropout, so they're going to decrease as the diabetic retinopathy increases. So how do we use this in clinic? It's difficult. There is no universal quantification system right now. Many systems don't even have a way to quantify vessel perfusion or vessel densities. The one from the machine from OptiView, which is now VisionX, they do have some automatic quantification, which is great, but the Spectralis, for example, and the Zeiss Cirrus that I'm using, which is an older model, doesn't have any sort of automatic quantification. So most of the times I'm looking at these maps, it's very subjective, and I'm not actually getting sort of this quantitative metric. There's no clear guidelines on how these OCTA findings should influence our care. So a lot of times, if you're bringing somebody back maybe a little early because the OCTA just has more non-perfusion than you would expect based on what you see clinically, it's a lot of our intuition or a lot of what we've learned of experience. There's not any good guidelines. So this is something that's constantly evolving. And I liked this quote from the preferred practice patterns that although the technology is FDA approved, the guidelines and indication for use during screening and management of DR are currently evolving, right? So there's no true guidelines for how we should really be changing our monitoring or our timelines of monitoring these patients. There's, of course, a couple limitations of OCTA. Many of these are continuing to improve with faster scans, improving technology, but one of the main issues is sort of that lack of universal segmentation algorithms that we discussed a little bit ago. Now, OCTA has already been used in a lot of the clinical studies that the drcr.net has been doing. But recently, in 2021, they had this publication that the quality was just not sufficient across all of the clinical sites to be able to use OCTA metrics as outcomes. So they really need to be improved and maybe better standardized from clinic site to clinic site. And sometimes the patient cooperation makes a big difference as well in the quality of the scan that you're going to get. So we'll walk through a few more cases here, focusing on OCTA findings. This was a 24-year-old female, type 1 diabetic, diagnosed about 8 years ago. Her full exam was completely normal. Her best corrected visual acuity was 20/20, no diabetic retinopathy. So a pretty quick exam, no major issues. We did go ahead and get an OCT and OCTA. You can see in this superficial vascular complex, it looks like perhaps there's a little bit of areas where there's sort of focal non-perfusion that we might not see in a normal patient. When we go to this deep vascular complex, and particularly when we're looking at this foveal avascular zone, I can certainly imagine that maybe there should be a capillary here or here. I can't say for sure, but this definitely has some acircularity to it that seems very suspicious for some lost capillaries. Now, did this scan change how I manage the patient? No, it didn't. Even if there is non-perfusion there, true non-perfusion, it's not, for this patient in particular, it's not changing how I'm monitoring that patient. So she's coming back in a year. But I am very happy that we have now established a baseline OCTA that we can now longitudinally follow these patients over time and look at their perfusion status and how it's changing with respect to their diabetic disease, okay? So I think getting a baseline and watching these patients over time is really important. And just to kind of show you a difference, so again, this is this 24-year-old, and then this is a 50-year-old with a 23-year history of type 2 diabetes. And again, maybe we see some slight irregularities, but this patient also has no clinically detectable retinopathy. And so when we're getting baseline scans, it's hard to say for certain without longitudinal data how much of this is truly non-perfusion versus just how they are. Vascular patterns from patient to patient vary tremendously, and particularly the size of the foveal avascular zone. There's a huge range of the size of it in the normal population. So I would encourage you, especially in these patients that don't have clinically detectable retinopathy, not to jump to conclusions. Make sure you're getting longitudinal data and seeing how that FAZ is changing over time. This is a 60-year-old female. She's a type 1 diabetic since the age of 34. She had actually been seen in our clinic 6 months prior and had mild retinopathy diagnosed. She was supposed to come back in 1 year, but she came in 6 months for another complaint. We ended up dilating her, and there was this little area of blood vessels that I was very suspicious were neovascularization or IRMA. I'll kind of zoom in on that, and this is with an Optos. I really like going to sort of this infrared Optos image because I can really see these irregular vessels. And so, of course, we did an OCTA to kind of find out if this is retinal neovascularization or was this a very prominent area of IRMA. Of course, we didn't get the best OCTA scan in the fovea, and this is common. These black lines going through our scan are motion artifact. So if the patient is not staying still and moving their eye a little bit or their body, then you can get these motion artifacts that are really common to OCTA, right? Because we're basing this off of motion contrast, but hopefully you can still appreciate that in the superficial vascular complex and the deep vascular complex, we have a lot of irregularity of these blood vessels and some capillary non-perfusion. Now, where the OCTA really came in handy was looking at that area of irregular vessels. So we actually moved the OCT scan area over that area and did some imaging there. And what we really care about here is segmenting out the vitreoretinal interface, right? So we see these abnormal vessels, they are in the vitreoretinal interface, so they are coming up out of the retina. So OCTA is really helpful here to confirm if you suspect neovascularization, especially when it's subtle. Now, here is also a B scan from this area. The yellow that you see in it is areas where there's flow. So certainly in these areas where neovascularization was suspected, we have some yellow because there's blood flow there and those abnormal vessels. But one thing I do want to highlight here is you don't necessarily have to have an OCTA to do this. Before I had OCTA capabilities in the clinic, I would just move my regular structural OCT there because you're still going to be able to detect whether those vessels are sitting within or on top of the retina, and that might help clue you in to whether that's truly neovascularization or not. Of course, you won't be able to see blood flowing through it, but you can certainly see that there's some abnormalities there. This is an example of a patient that had very severe PDR. I saw this patient for many years. She had repeated PRP treatments done, which you can see some of this here on the infrared image. And she clearly still has a lot of neovascularization and continues to progress. It doesn't, when you're looking at this patient's fundus, of course, there's a lot of non-perfusion here, but OCTA can still be helpful, right? She has a lot of non-perfusion. When we look at this area over the fovea and the deep vascular complex, a lot of non-perfusion and remodeling of that foveolae vascular zone. But we can also start to look at this junction between perfused and non-perfused retina. Now, she clearly has some little neovascularization fronds, but in somebody like this that is so far advanced, sometimes I like to be able to kind of see where that true border is so I know exactly where to look for very subtle neovascularization because it's encroaching on the posterior pole. And just again to highlight how, yes, OCTA is great, but you don't necessarily need it to see the neovascularization. If the neovascularization is close enough to the posterior pole, again, you can use your structural OCT to go ahead and do a B scan over that area. This is a very dense B scan. You don't always need quite as dense a B scan. Sometimes getting some more peripheral lesions is easier with just a few B scans. So I encourage you, if you don't have OCTA yet, to still use this or try this on some of your patients where you might suspect neo with your structural OCT. This is a patient with diabetes. They were referred into our ocular disease clinic for this retinal hemorrhage in the right eye, as well as just a diabetic retinopathy evaluation. And you can see right here, there's sort of this hemorrhage, a little atypical looking for a patient with diabetes, just based on diabetic retinopathy, especially because we do see a couple little microaneurysms, but we don't see a whole lot else. Again, here's this sort of area of retinal hemorrhage, and we do an OCT through that area, and this patient actually has this extremely large microaneurysm with a little bit of focal cystoid edema around it. Nothing that's affecting vision, certainly something that's warranting some more monitoring, though, to make sure that it doesn't progress. So really that kind of hemorrhage we were seeing was just these very large microaneurysms that this patient happened to have. This patient, we did do an OCTA, and you'll see that there are some areas of focal non-perfusion right off of the fovea. And of course, don't always only think of retinopathy as reasons why we might have non-perfusion, because if you maybe saw in the other image, maybe some of you caught it, this patient also has a Hollenhorst plaque. Now, I'm not sure this is actually causing any of this non-perfusion. It's certainly in the realm of that area, but this patient also has a Hollenhorst plaque. They were sent out for a workup. So remember, patients with diabetes, they have a lot of other vascular issues and really need a careful retinal exam with not just OCT, but multiple other imaging modalities. 5 months later, this patient still has this large microaneurysm, but it's been relatively stable, fortunately. This is another patient that I chose to do an OCTA on. This was sort of an atypical case. This patient really has a lot of cotton wool spots for diabetic retinopathy. And whenever I see this many cotton wool spots, especially in these locations, I want to make sure it's truly the diabetes. She recently had malaria and really had this acute elevation in her blood sugar. So a lot going on. We did decide to do an OCTA on this patient. I just wanted to make sure that she didn't have a lot of non-perfusion in the periphery and any neovascularization that I was maybe missing, because I suspected a lot of non-perfusion. Her OCTA, of course, she has several areas of non-perfusion, a little vascular loop right here. This is her right eye, obviously, and this is her left eye. But I just wanted to highlight, of course, newer instruments with wider field scans are becoming easier to get this peripheral information, but this is somebody that I imaged myself. This took me almost 20 minutes. So you do have to make sure that you have time, depending on what machine you have time in your clinic day to make sure that you can get these patients in and have a technician that can run these scans well. Some of the newer systems and faster systems, it's a little more time efficient, but still just something to consider. Fortunately, there is a new code for OCTA, so we get reimbursed, I think it's about $10 more than a regular OCT, so you are getting paid a little bit more for the extra time you're putting in. And then this is just how OCT can really help patient education. This was a patient that had been seen by our clinic the year before. They came back. The images from the year before looked something like this. So in the right eye, we've clearly got some neovascularization, a lot of ischemia that you can see out here. We've got a Roth spot here, and just a lot of retinopathy. In the left eye, there was already a significant vitreous hemorrhage. The left eye OCT obviously shows that sort of hemorrhage that we're seeing and this neovascularization off the disc, which is the source. Today, things are not looking much better. So the right eye, the patient still has good vision, right? The fovea is really not affected, but their neovascularization has advanced tremendously. They have numerous fronds all over now, a little bit of pre-retinal hemorrhage right here, these very abnormal vessels that have grown. And in their left eye, which is what brought them in, they now have a tractional retinal detachment. So this was an uninsured patient. They had been told to go to retina the year before, but they told me during this exam that they just didn't understand or think they were going to go blind. And so at this point, I just wanted to really let the patient know, you have to be able to save your right eye. And so we used OCT to really go through the scans, show him how this neovascularization is starting to tug on the retina and why he needs to go and get this treated. So I think if you just take the extra time when you have it, of course, to go through this stuff, especially in these very vision-threatening cases, OCT can be a very powerful tool for patients. Most people sort of understand a cross-section or the term biopsy, and so this really helps give them some insight into what's going on with their tissue. So just a few conclusions. OCTs really revolutionized care for our patients. We have this new, modern, updated OCT-based staging for DME, but we do need to make sure that we're using it appropriately and not just focusing on these very rigid stages. OCTA allows us to also assess the patient's microvascular status, level of ischemia, It's really useful, especially for longitudinal monitoring in early stages of disease, but clinical guidelines on how to actually use this data are evolving. A lot of this is based on clinical intuition right now when we're bringing patients back early. There is a new, as I mentioned, CPT code for OCTA. I think you get reimbursed about $57. You, of course, can't bill it with regular OCT for nerve or retina, but it is giving us a little more money for the time and effort we're putting in already often on these patients that we're doing OCT and OCTA. So really, in the future, OCT and OCTA is going to help us create more modern staging systems for patients with diabetes, which really haven't been updated for a very long time. And we'll learn better clinical guidelines on how to use this data. It's a great education tool, but please consider each case is unique. Don't get too hyper-focused on the OCT. Look at the whole picture. Don't lose the forest for the trees. And if you are considering adding an OCT to your practice, I would just make sure you explore all options, decide which is the best fit. Each system is very different. The outputs it gives you is very different from system to system. So make sure you become familiar with them and know what will be integrated best into your clinical practice.